This presentation is on pacemaking principles. We will be discussing both temporary and permanent pacemakers. So here are our learning outcomes. We're going to focus on why someone would need a pacemaker or those pacemaking indications. We'll review different types of pacemakers and then focus on what could go wrong once someone has a pacemaker in place. And that includes general complications as well as the malfunctions of a pacemaker, such as failure to capture, sense, and pace. And then we'll also look over a few EKG strips so that you can identify single and dual chamber pacing. So when do patients get a pacemaker? When is it indicated? Well, pacemaking is used to speed up slow rhythms that are causing symptoms. So think about that. This isn't for your marathon runner that has a resting heart rate of 45. That patient has bradycardia, but I bet if we checked her blood pressure, it's completely stable. She's alert and oriented, calm, and nothing is wrong. She doesn't really need any intervention. She's fine with a heart rate of 45. However, if we now have a patient with a heart rate of 45 whose blood pressure is 80/50 and he's confused and his urine output has dropped and now he's short of breath and maybe he has some dizziness or even chest pain, now we have symptomatic bradycardia. So the key here is not necessarily the heart rate itself, but the symptoms that are created with that heart rate. If that heart rate is not enough to perfuse my organs, I'm going to show signs of poor perfusion. Therefore, we say symptomatic bradycardia. And we're saying that we have a slow heart rate and that we've got symptoms of poor perfusion. So what do these patients need? These patients with symptomatic bradycardia. Well, they need a faster heart rate. They need that bradycardia sped up. So how can we make that happen as the nurse? Well, an easy intervention is administering atropine IV. But if that doesn't work, then we have to take over with something a little more intense, and that is sending electrical shocks to our patient's heart at a set heart rate that we want them to have. So for example, our patient who had that heart rate of 45 and was dizzy and confused, we could pace that patient to, let's say, 90 beats per minute. Therefore, we're sending 90 little electrical shocks to his heart each minute. We're basically pretending to be that SA node, that pacemaker, and we're taking over that pacemaking responsibility. So, symptomatic bradycardia. What EKG rhythms might this include? Well, remember, anything slow. So obviously this could include sinus bradycardia, but what other rhythms result in a slow heart rate? Well, think about it this way. Anytime you look at an EKG and you don't see enough R waves, that would be a bradycardia. So what about third degree AV block? I only see 3 R waves here, so my patient's heart is only beating 30 times a minute. Now, what about junctional rhythm? Remember, the intrinsic pacemaker of the junction is naturally slower. So if my patient were in this junctional rhythm, then I might see symptoms of low cardiac output. And even atrial fibrillation here. Now, much more likely than not, AFib is going to be a faster rhythm, sometimes uncontrollable with a rate of over 100. However, remember that atrial fibrillation is caused by unpredictable chaos fibrillation in the atria. And at times, this can result in an unpredictably low amount of electricity getting past that AV node and causing a ventricular contraction. So we may just see atrial chaos, but not enough ventricular responses. So this last one is pretty rare, but just keep in mind, all of these strips have something in common. It's a slow heart rate. There's not enough R waves. And remember, we're not only concerned about the heart rate itself, because we have rates of 30 and 40 here, we're also worried about what our patients look like. Yes, these rates are slow, but is that enough to perfuse our patient's organs? What are we going to see in our patient if this is not enough, if we're having symptomatic bradycardia? Now, we've determined that anyone with symptomatic bradycardia might need pacing. Now, how do we pace a patient? How do we send that little electrical jolt to their heart at that set rate of 80, 90, sometimes 100 beats per minute? How do we pretend to be an SA node in a sense? Well, there are actually a few different kinds of devices we can use to pace a patient's heart. And the key difference to be aware of is when each would be most appropriate, and also the risks that are posed with each way we pace a patient. So here we're going to discuss the temporary pacing modalities. This is not a long-term solution, and it actually requires a power source outside the body. Let's take a look at the first temporary pacing modality, transcutaneous pacing. Think about cutaneous and skin. These are pads on the skin. So first, to understand transcutaneous pacing, remember your code cart. On that code cart is the defibrillator. And that defibrillator can obviously defibrillate someone. It can also cardiovert someone, but it can pace someone. With a transcutaneous pacer, we are pacing the patient's heart with the same exact pads that we would use to defibrillate them, to shock them. And we're using the same exact machine, the defibrillator. Now the pads are actually placed, so one is on the chest and one is on the back. But think about how uncomfortable this must be, getting shocked at a set rate constantly through these pads on your chest and on your back. This is not an ideal situation. So transcutaneous pacing, pads on the skin, is an emergency situation. We do not want to have to do this unless we have to, unless our patient has symptomatic bradycardia and that IV atropine didn't work. So imagine walking into your patient's room, their heart rate is 30. They are unresponsive, their blood pressure is dropping. You tried to give them atropine and nothing is happening, so you have to do something. You grab the code cart, put a pad on their chest, right around where V4 would go, and a pad on their back between the spine and the left scapula. And you change the mode on the defibrillator to pacer mode, which you can see here. We select a rate such as maybe 80 or 90 beats per minute, and then we select a voltage, how much electricity we're going to actually send with each one of those beats. And now we're transcutaneously pacing our patient. So is this sustainable? Think about that. Do we want this patient to basically be hooked up to a defibrillator on the code cart indefinitely? No, this is again temporary, and this is an emergency situation. So as we're doing this, we're consulting with our healthcare team to get this patient a more sustainable intervention and to start brainstorming why is this going on and what else can we be doing. So let's look at the next two temporary pacing modalities, where the power source for those electrical shocks are coming from a source outside the body. Now we've talked about the pads on the skin, transcutaneous pacing. Now let's look at two more, transvenous and epicardial. Now these two types are more invasive than just putting sticky pads on your patient's skin. They require placement by a physician. And with transvenous pacing, the leads are actually threaded transvenously, so through and into the vena cava, and then into the right atrium. Sometimes those wires are threaded all the way to the right ventricle as well. So this sounds a lot more direct, right? Well, it definitely is, and it often requires less electricity and is more comfortable for the patient since we're closer to the heart. Now, our last temporary pacing modality is epicardial pacing. And this is our most invasive way to temporarily pace a patient. These patients' pacer wires are not pads on the chest like transcutaneous. They're not even threaded through the vena cava like in transvenous pacing. These patients' pacer wires are actually inserted into the epicardium itself. So one end of the wire is embedded in the surface of the heart in the epicardium, and the other end of the wire is actually passed through the chest wall, comes outside the patient's body, and is connected to that power source. So this requires cardiac surgery. So you can see we've gone from putting sticky pads on a chest to passing a wire through a large vein to actual cardiac surgery and putting a wire into a patient's epicardium. Thus, our last mode, epicardial pacing, is really the most reliable and often the most comfortable for the patient. It's the best way to pace a patient in terms of reliability and giving direct electricity to the heart itself. But it's the most invasive and obviously requires a cardiac surgeon's expertise, and you can't really just do it at the bedside if you're walking into a patient's room. So just be sure you're aware of what each of these temporary pacing modalities is and some of the risks and benefits involved that we've talked about. Let's talk about some of the key considerations with pacers in general. So first, a key point to make here is pacing is only used for symptomatic bradycardias, not asystole. So if you think back to your lethal dysrhythmias, a patient with asystole is dead. They need CPR and epinephrine, not pacing. There is no underlying rhythm to pace. So now remember, our more invasive temporary pacing modalities are transvenous and epicardial pacing. As with anything invasive, we need to be on the lookout for bleeding and infection. But also think about where these wires are. We're also placing our patients at risk for perforating lung tissue, causing a pneumothorax potentially, or perforating the myocardium. So while these two are more reliable ways to pace our patients, we need to be very vigilant about potential complications of transvenous and epicardial pacing. So take a step back for a second. We're pacing our patient who had symptomatic bradycardia. Now what? How do we evaluate if this is even working? Well, those symptoms from that symptomatic bradycardia should be improving. All those signs of poor perfusion and low cardiac output should be diminishing. Our blood pressure should be normalizing. Maybe our patient becomes more alert or is less dizzy. So think back to basics. If the point of me pacing my patient is to increase their heart rate and truly improve their cardiac output, then I should start seeing signs of improved cardiac output. Now, on a second-by-second basis, I can look at that EKG strip and see if the pacemaker itself is doing its job. Is it delivering enough electricity? Is it delivering impulses at the right time? Is the patient's heart responding appropriately? And this is when we get into the nitty-gritty potential malfunctions of the pacemaker and how to watch for those. So we'll discuss those next. So let's look at an EKG strip of someone with a pacemaker. Now, a patient who is being paced will have a different looking EKG strip than a patient who is not being paced. When a patient is connected to a pacemaker, that pacemaker delivers little zaps, little amounts of voltage at a set rate of, let's say, 80 beats per minute. So in addition to their underlying rhythm, I should actually see those little zaps from the pacemaker. And what does this actually look like? Well, those zaps are actually called pacer spikes, and a pacer spike is often just a vertical line. Remember, the vertical axis on our EKG strip is voltage. The vertical line represents a little bit of voltage coming from the pacemaker, and it's typically given very efficiently, so it will often just look like a little line or even a very tight, very narrow V. So let's look at a normally functioning pacemaker first. The purpose of that pacemaker is to deliver an impulse which causes the heart to beat, right? So we should see a pacer spike immediately followed by a sign that our heart is beating, which is our EKG complex, our PQRST. Now remember, with transvenous and epicardial pacing, we can actually specifically pace the atria and maybe the ventricle. So how can you tell which one is being paced? Well, remember, P waves are associated with the atria, and QRS complexes are associated with the ventricles. So a pacer spike followed by a P wave is in the atria, and a pacer spike followed by a QRS is in the ventricles. All right, so let's take a look at this. Here you can see a vertical line. Sometimes they point up, sometimes they point down. That's really not as important as just identifying the spike itself. So right after that vertical line, right after that pacer spike, we see a P wave, and it's kind of flattened, but we can see it if we look closely. Now also notice that this pacemaker is doing its job. My rhythm is nice and regular, which is the sign of a machine pacing my patient. And I can see that every pacer spike leads to a PQRST. So this tells me that this patient is atrially paced and it's working appropriately. Now let's look at a ventricularly paced patient. Right away, I see some awkward vertical lines, those pacer spikes, that doesn't look like a regular EKG strip. Those are my pacer spikes. Now, rather than that vertical line being followed by that flattened P wave, I see this widened QRS complex. This patient is ventricularly paced. Notice that whenever a patient is ventricularly placed, that QRS will not look normal. It won't be less than 0.12 seconds. It'll be a little bit wider, as you can see here. Now, this isn't a PVC, this is just a paced patient, a ventricularly paced patient. So now what about dual chamber pacemaking? Well, this dual means two, so both the atria and the ventricles are being paced. So maybe this patient has third-degree AV block, right? So we have to pace the atria, but if we just pace the atria, the signal is still not going to get to the ventricles. So we have to pace the atria and the ventricles so that the atria fill up, pump the blood to the ventricles, and then the ventricles contract. So what we do here when we're looking at the EKG is we just combine the two things we just learned. So we see one pacer spike and a little P wave, and then another pacer spike and a widened QRS complex. So let's take a little quiz. Looking at this first strip, what is going on with this patient? Pause the presentation and consider your answer. So I see a very skinny line that does not look like part of a normal EKG rhythm. That's my pacer spike. And it's followed by a wide QRS complex, and that just keeps happening over and over throughout this strip. So I remember QRS refers to my ventricles. So this patient is receiving a pacer spike in the ventricle, and they are ventricularly paced. Now let's look at another strip. What's going on with this patient? Pause the presentation again and consider your answer. So again, I see a very skinny vertical line that does not look like part of my normal EKG rhythm. Now, what is following that pacer spike? I see a tiny P wave followed by a QRST. So there's only one spike, then a P, QRST. So this patient, because that P is associated with the atria, is atrially paced. Last, let's look at this strip. So what's going on with this patient? Pause the presentation again and consider your answer. Now I see two skinny spikes. So the first spike is followed by a flattened P wave, and then immediately after that I see another spike, which you can see in this case isn't a perfectly vertical line. It actually looks like a very skinny upside down V. But remember, this is still a pacer spike because what follows it? A very wide QRS. So I see pacer spike, P wave, pacer spike, QRS. So this patient has dual chamber pacing. Now we've looked at different types of temporary pacemakers and what the EKG strip will look like, but what about if something goes wrong? Well, we call these pacemaking failures. That's when there's a problem with the pacemaker itself and its relationship with the patient's heart. So there are three major pacemaking failures, and these are called failure to pace, failure to sense, and failure to capture. And to break these down in simple terms, either the pacemaker just isn't sending electricity, or the electricity is being sent at the wrong time, or the heart isn't responding to the electricity coming from the pacemaker. So first, let's look at when the pacemaker just isn't sending electricity. That's failure to pace. And it's exactly what it sounds like. The pacemaker isn't pacing. So think about it as the pacemaker just being turned off. That's not actually what's happening, but it makes it easier to understand. So now this may happen all the time or for a longer period of time, or it could just happen for a few seconds. But in a sense, we just don't see pacer spikes when we should be seeing pacer spikes. So let's say your patient has a heart rate of 20 and the pacemaker should be delivering pacer impulses. You should be seeing spikes between those slow beats, but there's no spikes. We just see a flat line. So that is failure to pace. No spikes and a flat line where there should be a pacer spike and a QRS. So either it's just for a second or for a longer amount of time. Now next we have failure to sense. And in this case, we are pacing, so we do have pacer spikes. However, the pacemaker is just kind of ignoring what the patient's doing on their own. The pacemaker isn't sensing the patient's underlying rhythm. So rather than delivering a pacer spike in that slow space between the beats, it delivers it right on top of another beat, totally out of turn. And this often looks like a pacer spike sitting on top of a T wave or somewhere else in the complex that it shouldn't be. It's failing to sense what the patient is already doing and sending out impulses at the totally wrong time. Now last, we have failure to capture. And in this case, we are pacing, electricity is being sent, we see spikes, and we're also sensing, so that electricity is being sent at the right times. It's not on top of another beat. It's between those slow beats. But the heart is not responding now, and that electricity is being sent, but we don't see a mechanical response, and we don't see a PQRST. So what does this look like? Well, this one's actually very easy to spot. It is just a lonely spike followed by a flat line. We paced and we sensed, but the heart didn't capture that electricity. It received electricity, but it didn't capture the electricity and turn it into a mechanical action. No PQRST. So again, failure to pace, the pacemaker isn't sending electricity at all. Failure to sense, the electricity is being sent at the wrong time. And failure to capture, the heart isn't responding to the electricity that's coming from the pacemaker.
So here we have failure to pace, and as you can see, it's fairly simple. We had pacer spikes, but there should have been one there where that green arrow is. There should have been a pacer spike there, but the pacemaker failed to pace. And below, it's a little harder to see, but you can see pacer spike, pacer spike, pacer spike, pacer spike, each of those followed by a wide QRS, and then you see a gap. And there should have been a pacer spike in that gap because it was on a rhythm, it was on a run, and then it just stopped. And even though it picked up after itself again and started up again, that was still a failure to pace in that small space right there. So failure to sense, as you might imagine, is a little more difficult to catch. But as I look at this, I see these little pacer spikes, and then I see a QRS, and then I start to see these random spikes later on top of the T wave. And so the pacemaker is not being sensitive enough to the patient's underlying rhythm. Therefore, I should probably turn up the sensitivity setting on the pacemaker. So it's failing to sense the patient's rhythm and pacing at the wrong places. You should always see pacer spike, wide QRS, or pacer spike, P wave. Or you may even see dual chamber, pacer spike, P wave, pacer spike, wide QRS. But if I have a QRS and then a random spike in the middle of the QRS, that's failure to sense. So the last issue we talked about is failure to capture. And if you remember, think of the heart catching the electricity and doing something with it. So if you just see electricity and nothing done, then you have failure to capture. So when we look at this green strip on the top, I see pacer spike, wide QRS, pacer spike, wide QRS, pacer spike, nothing. So the pacemaker did its job, it paced at the right time, and it actually paced, so no failure to pace and no failure to sense, but the heart did not respond to that one pacer spike, so that would be failure to capture. So failure to capture is actually quite easy to find because all you need to look for is just a spike with nothing after it. So we've talked about emergency or temporary pacemakers where, let's say your patient's heart rate just suddenly drops to 20 and you grab the code car and you put the patches on them front and back and you start to pace them using the defibrillator. That would be more emergent, more temporary. However, sometimes these patients start to have more chronic problems that really aren't fixed with medication or anything else and we need a more permanent fix, thus the permanent pacemaker. So you see here the generator is implanted in the subcutaneous tissue and then the leads or the wires are threaded down through the superior vena cava into the atrium and into the ventricle. Now it may be dual chamber, it may be just single chamber where maybe we just need one in the atria and we're done, or maybe we need one in the atria and the ventricles. It just depends on the patient. But a lot of patients along with this will actually get an implantable defibrillator along with their pacemaker so that just in case they go into ventricular fibrillation, they can get shocked out of that rhythm as well. So you may already realize that pacemakers not only come as permanent and temporary, but each pacemaker can have different characteristics. And so we now have these codes that help us understand very quickly what is going on with that pacemaker. So it actually goes up to 5 different letters now that tell us what's going on. For instance, the first letter will tell us which chamber is paced. The second letter will tell us which chamber is sensed. The third will tell us the response to sensing. The fourth will talk about rate modulation. The fifth will talk about multi-site pacing. So this is a lot of detail that I really don't want you to worry too much about, but just be aware that you may see modes that say VVIRO. And that just is telling the cardiologist and telling the CV-ICU nurse what is going on in each chamber of the heart and what is the settings of the pacemaker. This is not something I will test you on. I just want you to be aware that when you hear these letters being put together, that is just the pacemaker code, telling us a little bit more about what that pacemaker is doing.
So once our patient has a permanent pacemaker implanted, there are some important points to consider and discuss with your patient. And just remember, as with any patient teaching, this individual has just undergone a stressful event like surgery. They could be scared or intimidated, and they may not process everything you say the first time around, and just handing them a packet is not enough. You need to find a teaching guide and something to provide to them to refer to and have them teach back as well. So you'll find a teaching guide in your text that you can refer to for some details. So first, you need to make sure that the patient knows how to check their own pulse. Have them actually perform this in front of you and verify that they're doing it accurately, so you're checking it as well. They should know what their target heart rate is and what heart rate they should inform their cardiologist about. So for example, if your heart rate drops below 50, you need to call your cardiologist. These patients should always carry a pacemaker card, and that includes the manufacturer information, the settings of the pacemaker, other key details about the pacemaker. If the patient ends up in the hospital, they can just bring this out and show it to their nurse and their cardiologist to make sure everybody's on the same page. They should also wear a medical alert bracelet indicating that they have a pacemaker. These patients will also need consistent follow-up with their cardiologist and have their pacemaker checked on a regular basis. This checking is often called interrogation or interrogating the pacemaker, and we're just making sure it's functioning properly. Now, immediately post-op, when a permanent pacemaker is placed, these patients should go through that basic post-op guidelines, such as monitoring the incision for bleeding and signs of infection, but also they should avoid lifting the arm on the operative side to avoid dislodging those newly implanted leads. And the cardiologist will want to determine when the patient can actually resume normal range of motion again. So the patient should also protect that site, so avoiding direct blows to the chest. And this might sound strange, but let's say that they have a very energetic grandchild. They need to be really careful around those kids that are not really aware of how forceful they might be. Not putting themselves in any situation where they could take a hit to the chest, so kind of taking it easy for a little while. They should also avoid high output electric generators, but know that being near or using a microwave is just fine. That is not considered a high output electric generator. And also a patient who has an MRI safe pacemaker can have an MRI, but nobody else. A patient with a pacemaker that is not MRI safe should not have an MRI. And even if they do have an MRI safe pacemaker, there are specific guidelines that should be followed. So these are just a few of the general guidelines that we need to review with our patients with pacemakers. But if you have any questions about permanent or temporary pacemakers or anything else that was discussed in this voiceover, I encourage you to post these to the discussion board.